New Year, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. Today on the podcast, I'm talking to GP Dr Tommy Perkins and Andy Pow from Medics Money about the financial year ahead for general practice. Medics Money has a website, podcast and a number of courses that provide doctors with education and support on all things to do with money, including personal finance and practice finance. Coming up in this conversation, we're talking about the financial pressures practices will face in the year ahead because of the rise in the national minimum wage and employers' national insurance contributions. We're also talking about the importance of making sure local enhanced services are profitable for your practice. Tommy and Andy also talk about how the GP contract needs to change going forwards to ensure practices are more sustainable, problems with GP premises, and offer some advice for GPs on their NHS pension, including for those affected by the McCloud remedy. Just a quick note before we start, this conversation was recorded just before the government announcement in December that GP funding would receive an £889 million funding boost for the 2025-26 GP contract. As yet, there is no detail on how that additional funding will be distributed to practices, so much of what Tommy and Andy talk about when it comes to funding and the national insurance contributions increase is still very relevant. Nick and I will be talking about the government announcement and what we know about the GP contract in the next week's episode. I'm delighted to be joined on the podcast now by Dr Tommy Perkins and Andy Pow from Medics Money, who regular listeners may remember from previous episodes. Tommy is a GP partner who set up Medics Money with fellow GP Ed Cantelo to help doctors better understand financial issues. Andy is a specialist medical accountant and has spent many years working with GP practices, supporting them with their accounts and their finances, and now also works with Medics Money. Medics Money has a very successful podcast that you can find on all the usual platforms that provides advice on the many financial issues that affect doctors, including pensions and tax. And Tommy and Andy are here today to talk about the financial year ahead for general practice and some issues that GPs need to bear in mind. Thanks both for coming on the podcast.
Hi, Emma. Thanks for inviting us again.
Yeah, absolutely. Thanks for inviting us back. We must have been at least okay last time we came on.
Well, I remember, I think we did this time last year. So we started off 2024 with you and we're starting off 2025 with you as well. So firstly, probably the biggest financial issue practices are going to face in 2025 as things stand at the minute is the increase in employers' national insurance and the rise in the national minimum wage, both of which are due to happen from April. What are the practices you work with telling you about the impact this is going to have on their business?
First thing, I just want to clarify here, because there's so much talk in the press about certain parts of the NHS being exempt from these national insurance rises. They're not. The legislation doesn't create a separate class of national insurance for hospitals or ICBs and things versus general practice. Everyone is going to have to pay this higher rate of national insurance. The question is really about what funding will flow to that. The issue is huge because what we know and what is certain is the impact in terms of the cost. So we know that actually we can model quite quickly what the national insurance cost is going to be. To a certain extent, you can model the national minimum wage adjustment where you've got people below that new limit. But what the difficult bit is actually, it's more than that. There is also then what I call national minimum wage creep, and that's everyone that gets paid above the national minimum wage will want to try and keep that differential going. So that's the slightly harder thing, and that's going to be very individual to every practice. But we're seeing all of them are going to face significant costs.
And Tommy, how is it going to affect your practice?
I think the kind of modelling is, in the order of £3 to £4 per patient is what Andy's saying. Certainly that's the kind of effect that we are feeling. So I think maybe just stepping back slightly, GP is a business and it's a business which helps people and makes them better. And I still think it's the best business that I've ever been in and I still love it. But that business has to make money so that we can pay our staff and also pay ourselves. And thanks to the unique structure of GP practices, which are mostly unlimited liability partnerships, if that GP business goes into debt, that is partners' personal assets, houses, cars, and other assets on the line, thanks to the unlimited liability structure. So as a business owner, aka a partner, the only responsible thing for me to do is look at this and say, okay, our costs have gone up significantly thanks to this national insurance tweak. And the financial year, is starting in April. So I need to make decisions now. So hopefully this segment goes out of date and some kind of fix is applied. But even if it doesn't, in my practice and hundreds of other practices that we work with in a Medics Money partnership course, they've already made decisions for next year because we have to, because it's like 3 months away. So We've modeled the cost for our practice. It is significant. We've implemented a hiring freeze, and we're accelerating other things that we've already been doing, which is essentially, unfortunately, having to cut back services, because as partners, we can only provide the service that we're funded to do. And if we go over our budget, the hospital, they go over budget, they get bailed out, or the magic money tree gets shaken and they're all okay. For GP partners, if I go over budget, someone's going to come and take my house as collateral. So even if there is a fix, and I hope there is, we've already made decisions for next year which will impact the services that we provide for patients, because we can only provide what we're funded to provide.
Additional funding from the government could cover maybe all or some of these costs, but at the minute it seems that will probably come as extra funding through the GP contract rather than as an exemption. Obviously, the problem with that is it means there will be potentially winners and losers, and maybe some practices won't receive enough money to cover these extra costs. Andy, can you explain why that is?
If we look really what's happened probably since 2019, the bulk of any sort of annual contract adjustment has been through the global sum, and that's linked to the weighted list size, not linked to the actual list size, but it's not linked to the specific costs of the practice. We had this problem the last 2 years when the government announced that GP staff should get pay uplifts of 5-6% and put some funding into the global sum, but it actually didn't match what was needed for a lot of practices. It does create winners and losers. And the reason why it does create winners and losers is the structure of the practices set up under differ. Just take an example. If I had a 10,000 list practice, if it was a traditional partner-led practice, it may have a cost of, say, 700,000 for its staff. But if you had the same practice, which had perhaps half partners, half salary GPs, actually the wage cost would jump maybe to 900,000. If you then look at a dispensing practice in a rural area that has dispensing staff to run the dispensary, which is part and parcel of the service that's being offered, they may be $1 million. And then you've got lots of contracts, practices now offering other services. They have, maybe a dermatology contract and other things. So the wage structure reflects the entire income that a practice gets from all its sources, yet we're only getting it delivered through an uplift through the global sum. And that's why it's not worked the last couple of years. And I really do worry this time around that it's even more specifically a problem, because we're trying to deal with a bit of a one-off issue created by a tax charge. And it's just not going to work. You're going to have winners and losers. Hospitals might have the same problem, because the hospital budget may go up by whatever, 2 million, but actually if their wage cost is 2.5 million impact, then they're going to have a problem. So all in all, it's a bit of a mess that the government have created through the budget.
During 2024, we've seen GPs in England take collective action. Aside from limiting appointments, one thing practices have been doing is serving notice on work they're not properly paid for, much of this locally commissioned services. Do you think that practices are doing a lot of work at the minute that they don't receive adequate funding for?
Yes, they do. But there is a massive variability across the country, and this is part of the problem. We opened this kind of issue up to our GP community that we work with, which is over 400 GPs across the whole of England. We've got the full remit of where people are working, and the variability in funding is huge. Well, it creates what's got effectively a postcode lottery, depending on where your patient is, as to what services are funded by the ICB and what's not. And it goes back to, local enhanced service is a really important income stream. It's actually more important income stream now than QOF is. Generally, when you have a situation where your income is under stress, which is generally in the GP contract, people then start to look at their finances a bit better. When everything's good, you might be happy providing this extra service for free because it's good for your patients. But when actually you can't afford to do it, you actually start to look at it. And the industrial action has probably helped focus people's attention. But yeah, the big issue here is we're seeing massive variation. In where I live up in Lancashire and South Cumbria, it varied from the old CCG areas. The lowest was £9.50 a patient. The highest was £26.10 a patient. So you've effectively got in the same area, a £17 variance per patient in funding, which you take a 10,000 list, that's £170,000 of income. It is vast, and solving this is really important, and also making sure that the uplifts come through on this as well, because these again did not get uplifted with the uplift in the global sum last year. So it leaves a hole in people's budgets.
Tommy, have you found that you've handed back contracts or stopped doing services as a result of all of this?
Yeah, absolutely. So enhanced services are extra contractual work. That means they are optional. You do not have to do them. So if I'm looking at an enhanced service, I've got to weigh up several things. Does this enhanced service benefit my patients? That's kind of a good thing. Do I have the skills to deliver the service? And is it profitable? It might seem a bit obvious, but revenue does not equal profit. If you get paid £50,000 for an enhanced service, but it costs you £75,000 to deliver, you have just subsidised the NHS from your personal bank account as a partner to the tune of £25,000. So we see in enhanced services the biggest gains in our partnership course. Obviously not guaranteed, but one practice was doing work that they weren't getting paid for through no fault of their own, and they managed to claw back £56,000. I spend a lot of time looking at my enhanced services, and I know how much each one makes, what is the profit margin. So to do that, you need to know your costs and look at how much time it's going to take you and the resources that you need. And then you need to think, okay, how can I streamline those resources? For example, could you use some automations? Could you send text messages rather than sending letters or making phone calls? And just keep trimming it down until you think you can make it pay. So for any enhanced service, just get your costs out, get the revenue you're going to get, and then income minus costs equals profit. It is kind of that simple. I would also reiterate what Andy said. The leses have not been uplifted for inflation in most areas for something like 6 years, right? And we all know how much inflation and costs have gone up, and yet the amount that you're getting paid has not gone up. So if you costed this up really nicely like I do 6 years ago, you need to run your sums again, because if it's not profitable, you're subsidizing the NHS. Huge disparity between areas again. For me, as I said, I love being a partner, still do, and I'm way past the honeymoon period. But one of my least favorite things is having to cut things back, which I know would benefit my patients. And this enhanced service thing is giving us some really difficult decisions for partners, because we are having to cut back things which we know our patients need, which we know our patients would benefit from, which we know when we push this work back to the hospital, the overall cost to the NHS is going to be higher. But we have no choice, because we can't keep doing unfunded work. Otherwise, we will go bust and we won't have a general practice left.
Yeah. Andy, is there any other advice you'd give to practices about locally negotiated services? There was some good advice there from Tommy. Should practices be reviewing those costs and things like sort of annually to make sure it's still profitable at the start of each year?
Yeah, absolutely. We've got a little model with our community where it allows you to model it. You've got to look at the costs, but it's not just the wage cost. It has to contribute to the overheads. So any practice will be paying the heat and light of its property. It'll be paying stationery costs, telephone costs, etc. Any service it does, be it global SAM or local enhanced service, QOF, etc., that income has to cover not just the wage costs, but cover those costs as well. But also it has to deliver a profit, and profit often is felt as a bad word in the public sector, but actually profit is what pays the partners. If we didn't pay the partners, they wouldn't be there. So you've got to have those three components in place. So you've got to go and review it. So you've got to do that process, because you've got to have the data, because commissioners aren't just going to say, we want to be paid more. Oh, yes, go and have some money. Actually, if you've got the data, you can go back and say, no, you're paying us X for this service, but we've calculated its cost Y, and here's our figures, and this is the reason why.
I was at the England LMC's conference, and there was a lot of people we were talking about how collective action had gone. And one of the things that they were saying is by doing this, by looking at enhanced services and handing back contracts or deciding they were going to, these were LMC representatives standing up saying this. In some cases, they had managed, the ICB had come back and said, oh, okay, well, we'll pay you more for this because actually it's better for GPs to be doing it. So not necessarily the massive pay increases people wanted, but some increase. So it's worth doing it from that point of view and working with your LMC on this just to see if something might come from it, isn't it, really?
Yeah, just to say on that point, absolutely it's worth doing. And yes, I do have a reasonable selection of locally enhanced services in my area, but it's because our LMC has been really fighting for it. So about 3 years ago, they massively cut the ear syringing payment, and we ran the numbers. They didn't look profitable, and the LMC organised everyone. We handed back the contract, and guess what? About 6 months later, we got a new locally enhanced service with a much better payment term. So this is a great chance for practices to make a stand and put a line in the sand. The BMA resources on this are really excellent, I have to say. And we had Katie Bramwell-Stone on our podcast recently, and she talked about that a lot. So just check out those collective action resources. Like worst case, you're going to realize you're doing a load of unfunded work and you're going to save yourself a load of money. But best case, you might be able to put pressure on your ICB to say, look, we are doing this work for free. We are handing it back to you. You can deal with it. And if you want us to do it, then send us a contract that makes sense, is costed appropriately, and we will consider it as the extra contractual work that it is. I said one good thing about the BMA there, but one slightly annoying thing is I really wish that they would pool all the data and address this disparity between areas. Some areas are getting nothing for doing CLL monitoring. Other areas are getting £95. Some are getting £45. There's such a postcode lottery for patients, right? Don't forget this is a lottery for patients and partners, because we've pulled the data together, of the 400 people in our online community, and it's absolutely wild variation. But the BMA are in a great position to pull that data together centrally, nationally. And if someone's getting paid £1 and someone else is getting paid £50 for exactly the same bit of work, that would be a great thing to campaign on. So that's my plea.
Weirdly enough, though, that's what we used to have. If we go back 20 years ago, I'm old enough to remember it, or when the current iteration of the GMS contract came out, we used to have things called National Enhanced Services.
Yes.
So they weren't the DESs and they weren't the LESs, but a National Enhanced Service was basically a picking menu of services set nationally in terms of what it's going to be priced at, so therefore negotiated nationally, which local areas could choose to commission or not commission as they wanted to, and practice could choose whether they want to take that up or not. We almost need to go back to that and sort of say, well, spirometry is going to be priced at X, Y, and Z for the different levels that you're doing. It's up to the local area where it wants to commission it from. But if you're commissioning it from general practice, that's what you're going to pay for it. And that will take some of that variability out. And we seem to have lost that.
We're talking about contracts here. We know the BMA wants to negotiate a completely new GP contract. I mean, it's not quite clear whether or not the government is up for that at the minute, but it might be, depending on what it wants to do in the 10-year plan. If there is a new contract, it's not likely to happen until probably 2028, but obviously there'll be changes from April. What would you both like to see in the contract from April 2025? How would you like to see things change?
What's happened the last couple of years, we've had practices with significantly below inflation uplifts, which has led to issues in terms of some practices become unsustainable. You draw a curve of practice profitability. There is a growing number of practices at that bottom end of the curve, and they're the ones I worry about because they're the ones that can quickly go to being sustainable to non-sustainable. So we're going to have to address that, and generally you would say addressing that through overall uplift in funding. But if we go completely just straight through the global sum route again, we're just going to keep perpetuating this problem over time. So what can they do? One of the biggest issues and we've got is around flexibility of PCN funding. We have some areas that are quite good in terms of making sure that practices get the resource down to practice level versus others that say, no, it's got to stay at PCN level. We can't do anything about it. And so I would like to see them come out and say, look, okay, we've got this overall funding issue. This is how we're going to deal with it. And one of the things could be, actually, let's look at the existing pots of money and where they get allocated. So shift some of that PCN money around, but leave it to local areas to decide. So, some PCNs will say, well, actually, we've committed on that spend and they won't be able to do anything. But other areas haven't. They're underspending. So let's get the money to the right place. We need to start working on these locally enhanced services. We need to start moving back to a nationally agreed list of pricing and also a nationally imposed situation down to local areas to say, right, we expect a minimum investment per patient in your GP practices of X per patient so that we start to reduce this variability. But we're at a point where probably we need to be moving to starting to think radically now about what the future looks like, because this contract is not, by then it's going to be 21 years old in its current form. 21 years ago, general practice wasn't doing what it's doing now. It's just not, it's changed fundamentally.
Tommy, what are you hoping to see from April? What do you hope will come out for this next financial year?
Yeah, I made a massive long list, but then I realized you probably didn't want like a 4-hour podcast. So I think I would just summarize it as just support general practice. Time and time again, general practice has proven that it can do a great job at looking after people and making them better. And of course, support means funding. I think no one's debating that. Our costs have gone up massively. The funding has to flow through or the cuts are going to continue. But also work with us, trust us to deliver the best care for our patients. GPs historically have been really, really good at that. So that means, of course, funding, but also giving us the frameworks to do that. Let's reduce bureaucracy. I mentioned locally enhanced services. The bureaucracy that I have to go through in order to do that, probably I spend 5 minutes with the patient and 15 minutes ticking the boxes and making sure the codes are done on the right date and the right time. I would love to be the other way around, 15 minutes with the patients and 5 minutes quickly making sure that the box is ticked. So let's strip back some of the bureaucracy. But my main wish is just stop this short-termism. Everyone's talking about a 10-year plan. I would love to see that, because at the moment it feels like we've got a 2, maybe a 4-month plan. At the moment we've got like a 3-month plan, haven't we? So you can't run a business or a service on that kind of short-termism. One thing that I reflect on a lot as a partner is, are we still doing a good job for our patients? You know, that's why we all became doctors, to deliver the best and, you know, give our patients the very best chance to get better. And I feel like that GPs are doing that at the moment, currently, but it's very, very difficult. And it feels like GPs are doing that despite NHS England and not because of NHS England. And I would like that to feel a bit different, like they actually understand how GP works and that they support us and not just sling us random bits of money 2 months before the contract expires.
And if there is a big, massive overhaul of the contract, I mean, what do you think needs to happen to make general practice more sustainable? Is it just about funding?
I mean, in terms of the contract structure, I think it has to change. I mean, I think everyone has always said that the Cahill formula has never worked. And in fact, we had a report from the Nuffield Trust, which came out in December, which talked about fairer funding in general practice. And again, that was reiterating that actually the Cahill formula now is just so redundant in terms of an allocation model. It's just not hitting any of the areas it needs to. So we have to move away from that. And to a certain extent, there's been such a great big emphasis on per capita funding. So the bigger list size you have, the more funding you get. There's no measurement of actually what you're delivering. Yet from an accountancy profession viewpoint, you know, what do I charge my fees on? I charge my fees on what I'm delivering, the time I'm putting in for my clients. So I would like to see at some point there has to be a reflection, not just simply in terms of numbers of patients you have on your list. It has to be a reflection of the services that are being offered and the number of appointments, either, you know, in person, telephone, digital, whichever way of dealing with it has to be reflected in what you're getting funded. Because if you encourage people to deliver services, you will deliver more services. That's what general practice is fantastic at doing. It will jump to the challenge and will do that, but it has to have the money that relates to that. I think also we need to, I'm in danger of going down the nostalgia route here for the old Red Book. I'm not saying we go back to the Red Book at all, but the Red Book had an element in there of some sort of fixed cost type of reimbursement. So if you look at the cost side of things, the 2 biggest costs GP practices are staff, by far, that's the biggest one, and premises. And if we move to a model which actually reflected some elements of staff reimbursement, it would take away the problems we've got now with national insurance and pay uplifts, and because that would automatically flex based on the staffing that's been agreed for your practice. But the other issue is property, and property costs are vastly different for practices. Now, we automatically at the moment have reimbursement for rent and rates through the contract. So big ticket property items are covered, but the service costs of running properties, and you have talked time and time again, it was on your podcast before Christmas about property issues and service charges in these premises and how that still remains a massive barrier to investment in general practice. If we can start looking at those type of costs, effectively taking out the global sum but reimbursed in a different way, then I think we go to a better position of reflecting both the delivery of services, but secondly, the costs of running those services. The danger is you will create winners and losers out of that, as we did back in 2004. What I'd really love to see would be actually we kind of a levelling up kind of process and saying, look, no one's going to lose, but we're going to invest. I suspect we won't have the money to do that as a country, and that's the problem.
Tommy, what would you like to see longer term in the GP contract?
Certainty and a plan.
Yeah.
You know, I'm a simple beast because at the moment we've just got massive short-term thinking, which is very, very difficult to run a business.
We talked about premises there. So the government has promised a £100 million fund to upgrade and improve existing GP premises. I mean, that's a drop in the ocean of what's actually needed to improve the primary care estate. What do you think actually needs to happen to improve premises? I know, Tommy, you're working in a practice where you are bursting at the seams. What would you like to see happen on premises?
Yeah, I think you're right to point out that 100 million is absolutely beyond a drop in the ocean. I think it's £2 million per ICB, I think is what Andy said, but he'll talk about that in more detail. But I think, again, it just goes to having a plan and some support. So yes, my practice is bursting at the seams because over the next 5 to 10 years, someone is going to build 4,000 to 5,000 new extra houses. Okay. That's fine. If we are adequately resourced, we can cope with that. So we have been trying to work with the relevant people to get the elusive Section 106 money. And it has been such a battle. Meanwhile, the houses are already going up. Our list size is going up. Space is tight. And we're still battling to try to get our hands on this extra funding and support. So we've paid out of our own pockets to get the plans drawn up. So we know what we need. We've had it all modeled out. But we just can't access the right funding. And that goes back to what I said, just give GPs what they need and we will deliver, but we need some kind of support. I shouldn't have to be fighting with developers and local planners and stuff to try to get the hands on the funding that we need. And if they're not going to fund us, then what am I going to do with the sort of 8,000 to 10,000 extra patients? Where am I going to see them? Now, we are, as GPs, we're always very innovative and we always think outside the box. So at my practice, because we have got a space issue, we do hot desking. So I think if you are tight on space, just have a look at your actual utilization of your clinical rooms, because it's a clinical room, that's a valuable asset. So once you finish your clinic, go and do your paperwork somewhere else. So we've got a little hub where we all do our paperwork together. It's actually quite sociable and you can get second opinions. So do some hot desking, some working from home, working innovatively. The way that we triage our patients has massively changed over the last 3 or 4 years. And so that's helped a bit as well. But fundamentally, if you build 5,000 houses on my patch, I'm going to need some kind of support in order to accommodate them. So that's what I want.
Yeah, well, premises investment has gone down substantially over the last few years. So I've got so many practices that are desperate to do an extension, but there's no funding that goes towards it. I mean, part of the solution to this is also not just actually building more space. It's, as Tommy said, using space better. It does need substantially more investment going in, which is going to be tricky again. I mean, 100 million, it is just over 2 million in ICB. You could spend that on half a surgery, really, these days. You want to build a modern surgery, you're looking 3-4 million pounds for something fairly decent. So it's not going to go very far at that level. What can people do now? As Tommy said, a good example in his practice is you've got to prepare ahead. You can start to pull that business case together now, so it's ready to go. So you can do your business case around, well, that's going to need X more members of staff, which I have to put somewhere. So you can do that business case around the space that you're going to need. If you can and have the money to invest in plans, at least some basic architectural stuff, cost it out as well, that's useful so that if these things do suddenly come on stream, you're in a position to bid for it. Because as we ever know with the NHS, it always waits last minute and then it's always got some money to spend really quickly, and it will spend it on the people that can go, here you go, here's the solution. So get prepared is really what I would say.
Yeah, that's really good advice, that. Right, so while I've got you both here, I wanted to ask you about pensions. I know that pensions is a big topic on your podcast. There's quite a lot going on with pensions at the minute, particularly for doctors affected by the McCloud remedy. Firstly, if people don't know, who's the McCloud remedy aimed at? Who does it affect?
Yeah, so this is why I've got grey hair. I used to have colour in my hair, but the status of NHS pensions and particularly the GP side of it, I've seen that drain away over the years and quite rapidly recently. So what McCloud is basically back in April 2015, in the whole of the public sector, this isn't just the NHS, a 2015 version of the public sector pension schemes. And they had a different retirement date, a different what's called a normal pensionable age, which actually was pushed out from, in the old 1995 NHS scheme was age 60, and this is now linked to state pension age. So it pushed retirement dates out. At that point in time, they moved people over into that scheme, but they had a protected group of people, older people, who were obviously quite keen and very good at lobbying at the time, who managed to get themselves protected in the old legacy schemes. There were 2 court cases. Judges and firefighters took the government to the courts, basically on age discrimination grounds. The government lost, so the government have been told to change everything. So what they're now doing is going through, and they have done this now, is rectifying pension records. So if you joined the NHS scheme before the 31st of March 2012, and you were transitioned to the 2015 scheme between the 1st of April 2015 and the 31st of March 2022, so 7 years, basically all of that career history is now going to go back into the old scheme you came out of, which has the earlier retirement dates. So that process is going on in the background. In fact, it should have really happened by now, albeit GP records being GP records, it's painful. They haven't done them all. So that's all going through. What will then flow out of that is a secondary thing in that some people have had to pay annual allowance pension tax charges, and particularly the higher earners, over that period of time. And annual allowance pension tax charges are paid when your deemed NHS pension growth is more than the government allow you. There's a tax charge that gets applied, and that, there was lots of coverage about that previously in terms of how that was impacting on people working. So those tax charges have been paid under the new rules, but they have to now be recalculated under the old rules because it's a different calculation. You couldn't make this up. So what we're currently going through is a situation where anyone that had an annual allowance tax charge has been affected by McCloud now has to resubmit 8 years, not just 7 years, 8 years worth of data to HMRC in the most difficult way they managed to possibly do it, through this online system where you've got to enter all the data for 8 years. And hopefully out of that, it will correct everything. What's made it worse, though, is a lot of people have not had these revised statements. So you have to receive what's called a remedial pension service statement. If you don't get one of those, you can't do anything. A lot of people haven't got it. Particularly GPs haven't got it because their pension records are a bit of a mess. But then they also got a load wrong. So the load of the initial batch that went out was wrong. They reissued a batch in December, but they reissued it with the instruction that if you don't receive a reissued statement, assume you didn't get one. Rather than actually, December's not a great month for post usually in this country. So it could get lost in the post, could have gone to the wrong address. It's chaos, really. The issue at the moment we've got in terms of January is we've got one of the first deadlines coming up, although it's a bit of a soft deadline, 31st of January 2025. And that's for anyone who ends up with a higher tax charge should submit their data by that point in time. If they don't do, the risk is they'll have interest charges and maybe penalties applied if they get it wrong. But I suspect there'll be a strong case for the whole system is a bit of a chaos at the moment. But yeah, we've still got loads of people that haven't had any information yet, which is a problem.
What advice would you give to GPs affected by this? What can they do now? Is there anything they can do if they don't have those statements?
For GPs at the moment, there isn't anything they can do. They have to sit and wait, at least minimum to February. Some of the advice that came out before Christmas was they hope to get this back on track by February. However, that doesn't deal with the group of people who still haven't got an up-to-date pension record. So we've still got a whole heap of people out there in the GP side, for whatever reason, can't get any information on their GP pension. And that generally then reverts back to the PCSC side of things, particularly in England, where, we've got people with missing records still. It's a lot better than it used to be, but it's nowhere near what you should expect of the pension system. You have to go back, work out what information you can get through either your My NHS pension statement, if you can access it, or your PCSE online portal. Try and work out where the gaps are and try and then find the information for those gaps and try and resubmit it. But it's a bit of an onerous process. It's a more of attrition in terms of just making sure you've got all those missing years that have been updated properly.
And is that advice you'd give to all GPs, not just the people affected by the McCloud?
Anyone that can access some data, it's really then also important. So what you will get with the pension system is if your information was up to date, it will give you an estimate of what your pension accrued is to date. It doesn't predict the future. It just says where you're up to now, and it should also give you all the breakdown of the earnings you've had over the years and where you've worked over those years. So any GP, if they can access that information, should go in and check it in detail. What you don't want to do is get to retirement and find there's a gap 21 years ago. And I've got a really good example, which is my wife, who's going through the process of claiming her NHS pension. And we got an email from the pensions agency going, back in 2001, you had this job. And they just get this ID reference for it. And we haven't got the hours recorded against it. Have you got pay slips for back then? And it's like, actually, it didn't actually affect her pension calculation. But if you get one of those kind of things, you're not going to have the data. So go back in and review it. And clearly I missed reviewing it. I didn't do my job properly. So apologies to Mrs. Pow out there for not doing my job properly. Check your record is what I would do. But those that have got missing information, it's a war of attrition, and try and keep persisting to get it updated.
Tommy, I just wanted to ask you, because obviously NHS pensions, it comes up on your podcast all the time. I know it does. And, the reason you set up Medics Money was because you thought that, doctors, they're clever people. They should have better awareness, understanding of financial issues that affect them. And obviously the NHS pension is a massive financial benefit to people who work in the NHS. What advice would you give to people about their pension?
Yeah, so I think, the reason that we set up Medics Money was that doctors get plenty of clinical education, but almost no financial education. And that's true of all doctors, whether GPs or not. But especially for GPs, still in GP training, we aren't really taught a great deal about the business side of general practice. And whether you're a partner, a salaried, a locum, the business of GP is relevant to all of us because we all need GP to be healthy and stable so that we have jobs. And so we would really love more training for all doctors. And we sat around and waited for it to happen quite some time, and then it didn't. And so we set up Medics Money about 7 or 8 years ago. And obviously Ed is an accountant, a tax advisor, and a GP, so that's quite useful. But still, 7 or 8 years later, we don't have significant training available. And of course, that's what Medics Money does. You've heard us refer to our course and our community. We've got several different courses, one for partners, one for all GPs, and one for all doctors. Come on those is a good start, but there's so much you can do yourself. So just take a little time to get educated, okay? And the Medics Money website is a good place to start, but there's other good places to learn as well, because the pension is still a great deal for the vast majority of us. It's an index-linked, inflation-proof income for life in retirement. But you can understand why GPs are getting pretty fed up with it just from listening to what Andy said. The wrong data, querying things from 2001, and it's not uncommon. And this has just been rumbling on and on and on for years and years and years. And GPs have sort of lost faith in that system, a bit disillusioned with it. But what I would say is, every time I ask Andy if he could swap his private pension for my NHS pension, he always says that he would swap. So just bear that in mind, that it is still a great deal for the vast majority of us. Take your time to get educated about it. And specifically for McCloud, which Andy was talking about, we've got some free publicly available content at medicsmoney.co.uk/McCloud for the basics, but we also have, if you've got your RPSS, your remedial pension savings statement, we have a YouTube video where we break it down, what you need to do, how to triage, and the next steps. And learning about your finances is significantly easier than medicine, in my opinion, but you do have to just start. You can't just put your head in the sand and leave it to somebody else, because unfortunately somebody else isn't going to help. And of course, there are tons and tons of experts like Andy's colleagues that are available to help you as well. So if you do need advice, definitely recommend a specialist medical accountant, and Medics Money is a great place to find one of those, or a specialist independent financial advisor. If you are going to get advice, make sure you get a specialist advice. And I think over 3,500 doctors last year found a new specialist advisor on Medics Money, over 20,000 total now since we started.
Yeah, we'll put a link to some of those resources in the episode notes as well. And finally, just before we finish, what other advice would you give to GPs and practices as we start 2025 about what they can do to ensure their finances are in good shape this year?
So I think we're going to go through quite a significant period of change. We're now a year into the new government by then, and you would hope to start to see some of the things they want to do. So it goes back to basics, really. Make sure you get your finances in order. Make sure you've got good systems in-house for reducing and reviewing your expenses. You can't cut expenses out altogether. You still got to have some expenses, but make sure you're getting the most value for your money. In terms of your staffing, make sure you understand your staff costs in detail, because that is the cost that's going to go up in April. Whatever funding comes your way, that cost will go up. So you do need to have a look at that. If you're in one of those areas that aren't working very closely with your PCN, there's some areas are fantastic, very integrated with their PCN. Other areas that aren't. The PCN is still key at the moment. So making sure you're using that PCN resource as best as possible help you for the future. And finally, go back to what Tommy said, make sure that you've got good advice around you. You're not experts in finance, but make sure you've got a specialist that does that. If you've got legal issues, get a specialist medical lawyer in. If you need your premises reviewing, get a medical specialist surveyor in. There's lots of good people out there who are available to help.
Yeah, Tommy, have you got anything you want to add to that?
Yeah, I guess my point would just go back to education. As a partner or any GP, you need to understand all your different income sources. And on our courses, we've got a slide, and I think there's like 20 different inputs and 20 different outputs. So have a look at all your income sources. Think about how can you increase those income sources? How can you maximize them? How can you drive efficiencies? There's so much amazing technology available in GP at the moment. It's actually a really exciting area that I really love. In the last 5 years, we've got an AI chatbot which summarizes my notes for me. We've got, the ability to respond to text messages and just simple things like that. We've got AI coding of notes, which is driving incredible efficiencies, but no one's going to do it for you. You've got to get out there and learn about it and do it. 100% echo what Andy said about having a strong PCN is absolutely essential right now. A lot of funding is going via PCNs, and you need to make sure that that funding that you are using to provide care for your patients and not anything that you don't need. So try to get your PCN working together. And there's a whole module on the PCNs because it's just so complex on our course. And finally, I think the power of community has been a real revelation to us in the work that we've done at Medics Money. We have an online community now of 400 partners, all working together, all saying, what are you getting paid for this locally enhanced service? Oh, we don't even have a locally enhanced service. So just surround yourself with the right people. And that includes your peers, like other partners or other GPs, and expert advisors like Andy, but there's other amazing expert advisors out there as well. So get educated. And once you do that, that's why I'm still very optimistic and I still love being a partner, because I know that how my business is running and I'm in control of it because I understand the inputs and the outputs.
All right, that's brilliant. Thank you both so much for coming on the podcast. Thank you.
Thanks so much for having us again.
Yeah, thank you.
Well, that's it for this week. Thanks for listening, and thanks so much to Andy and Tommy for taking the time to talk with me. I'll be back next week for our regular news review where, as I mentioned earlier, Nick and I will be talking about the government's announcement about GP funding for 2025-26 and what we know about the GP contract, so please do join me then. In the meantime, you can read more about that and keep up to date with all the other latest news affecting general practice on our website at GPonline.com.